Hi, I'm Ali Kılmaz. I'm a pediatric radiologist at McMaster Children's Hospital. I'm going to talk about malrotation of the midgut and related complications. So, malrotation and midgut volvulus are different entities. There are complications of malrotation. These complications can be peritoneal bands. These are also called Blad's bands, and they may cause intestinal obstruction because the bowel twists around these bands. And another complication is volvulus. Volvulus can be acute volvulus without necrosis, acute volvulus with necrosis, and chronic volvulus. This is rare. So first message is malrotation and midgut volvulus are different entities. There is no volvulus without malrotation. So when there is midgut volvulus, there is always malrotation. So why are we calling it midgut volvulus but not the bowel? Let me explain this by showing you some embryology. This is a brief overview of the embryologic rotation of the midgut. Arterial blood to the gut tube is supplied by the abdominal aorta. This is around a fifth week of gestational life, and the gut tube is composed of foregut with blood supplied from the celiac artery, and midgut, the blood supplied from superior mesenteric artery, and the hindgut with the blood supplied from the inferior mesenteric artery. During the fifth week of development, the midgut starts to loop ventrally, herniating into the umbilical cord. This growth process creates much of the resulting length of the intestines. And the cranial limb of this midgut extension will ultimately form the distal duodenum, jejunum, and proximal ileum. The caudal limb of this midgut extension will ultimately form the distal ileum, cecum, appendix, ascending colon, and the two-thirds of the transverse colon. So this is called midgut. So when the midgut is twisted, we are talking about all these structures. As the midgut lengthens, it also rotates 90 degrees counterclockwise around the axis of the combined SMA and umbilical cord. The cranial limb of the midgut, now on the right side of the umbilical cord, becomes highly convoluted through the next few weeks. The caudal limb of the midgut, now on the left side of the umbilical cord, grows a small cecal bud, ultimately becoming the cecum and appendix of the colon. During the 10th week of development, the midgut retracts back into the abdominal cavity, just like this. This is happening because the abdomen is too small for the bowel yet. So for 5 weeks, these midgut structures are located outside of the abdominal cavity, and then they return back. The midgut then rotates an additional 180 degrees counterclockwise, so a total of 270-degree rotation of the intestine or midgut. So this is an additional, and finally the duodenum, jejunum, and ileum are now inside the borders of the entire colon, which is composed of the ascending part, a transverse part, and the descending part and the sigmoid part. So this is the normal rotation of the midgut. After the rotation of the midgut, the mesentery has a broad base which avoids it to twist. However, when there is a failure of the rotation, the root of the mesentery becomes narrow and prone to twisting. So if you ever used market nets for the invention of the plastic bags, you will realize that you need to keep the neck of the net broad to avoid twisting. So when the neck is too narrow, it is prone to twisting around itself. So it's the same idea. If as a result of a failure in malrotation, the base of the midgut becomes narrow and prone to twisting. When it's twisted around, it's called volvulus. So not all malrotations are complicated by volvulus. And this is the result at surgery. So let me tell you the embryology again, because it's very important to understand malrotation. There are 3 stages. The first stage is between 5 to 10 weeks of gestation. Second stage is around 10 weeks. And the third stage starts around 11 weeks and continues until birth. The bowel returns to the abdominal cavity at stage 2, around 10 weeks. So there are 2 landmarks of bowel: DJ loop, duodenojejunal loop, and cecocolic loop. The DJ loop is located superior to the SMA at the position of 90 degrees. This is 0 degrees, 90 degrees, 180, and 270. And the cecocolic loop is located at the position of 270 degrees. So this is where they start. And during stage 1, the DJ loop rotates 180 degrees in the counterclockwise, and the cecocolic loops is rotated 90 degrees counterclockwise. Then stage 1 is completed, then the bowel is moved back into the abdominal cavity. During this time, when the bowel is going back, the DJ loop makes an additional 90 degrees rotation and the cecocolic loops an additional 180 degrees. So when we reach to the stage 2, the final position is the cecocolic loop at the position of 180 and the DJ loop is at the position of 0 degrees. After this one, the stage 3 starts and continues until birth, and the cecum descends and the DJ loop ascends and reach to their final anatomic position. So if there's a disruption during this embryologic development during stage 1 between 5th and 10 weeks, the resultant pathology is non-rotation. And this is the most severe form. If there is a disruption during stage 2 between 5th and 10 weeks, it's called incomplete rotation. And after 11 weeks, the resultant pathology is called incomplete fixation. So there is a spectrum. Not all rotation abnormalities are same. It could be more severe or it could be less severe. So in non-rotation, and this is the most common form, the most common complication is midgut volvulus. And the final position of the DJ loop is on the right side of the abdomen and the cecocolic loop on the left side of the abdomen. And as you can see, they are located in opposite sides. So in some of these cases, the mesenteric base can still be long enough and it doesn't have to twist around itself. So these patients may be asymptomatic. However, this incomplete rotation, which happens during stage 2, is usually complicated with midgut volvulus and also associated with lead spans. Lead spans cause intestinal obstruction without volvulus. It can be without volvulus as well. This is the most common surgically treated type. And here you can see the DJ junction and cecocolic loops are in abnormal position, and this is usually what we refer to volvulus. And stage 3 is the mildest form because the cecum is close to its anatomic position and the DJ junction is close, but it usually results with volvulus of the terminal ileum, cecum, and proximal ascending colon. There is also a very rare type of rotation anomaly, which is called reverse rotation, only 4%. It's an abnormality of the second stage of rotation, where the 270-degree counterclockwise rotation is replaced by a 90-degree counterclockwise rotation, followed by a 180-degree clockwise rotation, to a result in a net 90-degree clockwise rotation. Most commonly, the transverse colon is located behind the SMA and the duodenum, and there is compression of the colon by the SMA, and there is also associated ileocecal volvulus due to incomplete fixation of the right colon. So the epidemiology, the true incidence is not known. 0.5 to 1% of the population is affected in autopsy series. In upper GI studies, 0.2% frequency. And in symptomatic malrotation occurs in 1 in 6,000 live births. The presentation is early in life, usually 30% by the age of 1 month, 58% by the age of 1 year, and 75% by the age of before the age of 5 years. How is the clinical presentation? Malrotation is associated with many diseases, which could be congenital heart disease, especially heterotaxis syndrome up to 70%, congenital diaphragmatic hernia more than 45%, and omphalocele 45%. Here you can see heterotaxis syndrome. The heart is on the right side, and you can see that the DJ junction is on the right side. During malrotation and midgut volvulus, the presentation may be different. Malrotation is usually asymptomatic, could be insidious, could present with bilious vomiting. There is could be abdominal pain and tenderness, abdominal distension, chronic GI disorders, can be completely asymptomatic. However, midgut volvulus is usually presenting with bilious vomiting, more than 90%. They present as acute abdomen, peritonitis, sepsis, septic shock, and hematochezia. Bilious vomiting is very important. So if you return to our first slide, malrotation is an anomaly, is a congenital anomaly that may be complicated with intestinal obstruction or volvulus. The intestinal obstruction occurs secondary to peritoneal bands. Here, there are bands here. It's hard to see them. They're transparent. We can't really show them on imaging. But we can just show the secondary mass effect on the bowel loop. And volvulus can be complicated with necrosis. When the entire midgut is involved, it is not compatible with life. So if there is a delay in the diagnosis and it's too late, and there's ischemia of the midgut, it's too late. Even if you do a resection, even you feed the baby with TPN, and it's not compatible with life, you're going to lose the patient soon. There is also a rare type of chronic volvulus, which we saw. There you can see varicose, mesenteric veins, and these patients tend to reoccur, and they present with bilious vomiting and abdominal pain. Let me show you the Letz bands again. Letz bands are abnormal peritoneal bands that extend from the abnormally positioned cecum to the peritoneum or retroperitoneum and crossing the duodenum and in their course and causing obstruction. And here at surgery you can see it. These are the Letz bands. They are transparent, very thin. We cannot demonstrate them on imaging, but at surgery, as you can see here, they need to be resected. You can see here, they are causing obstruction. Here is an example of a lead band obstruction. This is a 6-year-old newborn presenting with bilious vomiting since birth. We do the upper GI study. There is a complete obstruction, and we can't really see the distal duodenum. Here, this is D1, D2, D3. We can see the proximal aspect of D3, but not the distal D3. It looks like a duodenal web, actually, but it's just an obstruction. And we can't really tell malrotation based on these images because we couldn't really fill the bowel completely, fill the duodenum completely. So what do we see on imaging? So on the X-ray, the findings are usually non-specific for malrotation. We are talking about malrotation unless we mention volvulus. So there can be a double bubble sign with or without sparse distal air when there is volvulus. On the upper GI study, this is gold standard. We can see an abnormal position of the DJ junction, and we can see duodenal obstruction secondary to compression of the Letz bands and corkscrew appearance when there is volvulus, and the entire small bowel located in the right abdomen. And in contrast enema, we can see an abnormal position of the ileocecal colon, entire colon in the left abdomen, and complete obstruction of the transverse colon. That's when there is reverse malrotation. And on cross-sectional imaging, abnormal position of the SMA or SMV. I mean, we are always talking about SMV because SMA is always in the center. Everything turns around SMA. So abnormal position of SMV, abnormal position of the third portion of the duodenum. And when there is volvulus, we can see Whirlpool sign, dilatation of the SMV and duodenum, the proximal dilatation. So these are the findings, and radiology is very important. However, don't delay surgical treatment of these patients with suspicion of volvulus with radiological tests, especially when they are hemodynamically unstable. X-rays will not cure the baby. Let me show you what we can see on a radiograph. This is a 5-year-old with bilious vomiting. Here you can see a triple bubble sign. That's one bubble of the stomach, second bubble of the proximal duodenum, and third bubble of more distal duodenum. So and there's also some distal air, as you can see here. In duodenal obstruction, we see double bubble. We don't see distal gas. So this is important. And also, ligaments of Treitz is important for the identification of the position of the DJ junction. It is suspensory muscle of the duodenum. The main branches are attached to the junction, but there are also other branches extending to the third portion of the third and fourth portion of the duodenum. We can't really see the ligament on cross-sectional images, but we can see the attachment position. It is usually The normal anatomic position is here at the level of the pylorus and left to the pedicle of the vertebrae. And here you can see the attachment. This is another illustration. D1, D2, D3, and D4. The DJ junction is at the level of the pylorus or above and left to the vertebral pedicles. That's a normal position. And it doesn't have to be the upper GI study. You can see the DJ position in a CT or MRI study, as you can see here. For the upper GI studies, lateral view is also important. This is the normal lateral view. D1, D1, actually D2, descending. D3 is the transverse. In an oblique view, you can see that D3, D4 is going up. So normally it's a U shape on the lateral view, but when there is abnormal rotation, the U becomes a reversed C because the fourth part does not ascend. Most malrotations will be seen like this. The DJ junction is on the right side, DJ junction is on the left, a little bit low, or just like here. This is from this article, and this is also a malrotation. The DJ junction is right to the left vertebral pedicle. This is the DJ junction is crossing the midline, but it's in low position. This is still a malrotation. Let me show you examples. In this upper GI study, we are doing this. It's not really obstructed, the bowel is. We can see the contrast passage. DJ junction is here. The vertebral pedicle is here. It's over the vertebral pedicle. It's important. The technique is important. We should make it sure that we have a true AP position and the patient is not rotated. And this was a malrotation with lat bands. Another example of a 14-year-old girl with malrotation. The DJ junction is in low position and in the midline, and the proximal jejunal loops are in the right side of the abdomen. We actually continued this rather than doing an enema, and the entire colon is on the left side, the entire small bowel is on the right side. This is a typical malrotation without any complications. There is no lat bands obstruction or no volvulus at this time. And we can also demonstrate this rotation anomaly on CT. The small bowel is on the right, the colon is on the left. Also in the MRE, small bowel on the right side, colon on the left side. So what about ultrasound and Doppler ultrasound for the diagnosis of malrotation? We routinely check the position of SMA and SMV in abdominal ultrasound. So what is the meaning of this? We are basically doing a screening to detect a malrotation. And if we catch it, the patient can have a surgery before a volvulus occurs, and we can save the patient's life. So what we check is the position of the SMA and SMV. SMA is in normal position as we expect. The SMV is right to the SMA normally, but if the SMV is on the left of the SMA or on the same position, then it's abnormal. And according to the position of the probe, it may be difficult. So if there is a doubt, you should draw a line between the aorta and SMA and IVC and SMV, and these lines should not intersect on this image, just like this one. So if they intersect, they are abnormal. As you can see the correlation here, the lines, these lines are intersecting and this is not. So checking for the position of SMA and SMV in routine abdominal ultrasound studies is for screening purposes of malrotation, just like checking for aortic aneurysm above the age of 50. Another sonographic feature for the diagnosis of malrotation or excluding the diagnosis of malrotation is third portion of the duodenum. So normally it's a retroperitoneal organ and it crosses the midline between the aorta and SMA. So this is the D3 portion of the duodenum. This is normal. We can also see them on cross-sectional studies. This is duodenum D1, D2, and D3, and crosses the midline between the aorta and SMA. So when you see this, you can exclude a malrotation. So how accurate is this? So Doppler ultrasound is about 70% accurate. If SMV is at the same position of SMA, then it's even lower. If you see this third position of the duodenum, how accurate is this? So initially, in 2009 on Pediatric Radiology, it was suggested that it's very, very accurate. 100% is the number, and they questioned, we are actually betting on the wrong horse by checking the SMA and SMV position. We should bet on the retroperitoneal position of the duodenum. And the numbers were really high. They actually confirmed these results, almost 100% accuracy, 100%, and almost every year there was another article showing how accurate this was. And then a few articles, case reports, actually were reported as exceptional. For example, this one, there was an exceptional case, even though the duodenum was between the aorta and SMA, it was a malrotation, and another one. So it is close to 100%, but there are always exceptional cases. But it's for sure more accurate than position of SMA and SMV, but technically determination of SMA and SMV position is easier. As you can see here, we can use this in cross-sectional studies. So on ultrasound, it's difficult, but on cross-sectional studies, we can easily see the D3 position of the duodenum. For example, in this case, SMV is slightly left to SMA. So is this malrotation? No, because I can see the D3 part of the duodenum and it's retroperitoneal, so this excludes, and this patient didn't have malrotation. So demonstration of retroperitoneal position of D3 to exclude malrotation is more reliable than SMA-SMV position. So let me show you a few slides how midgut volvulus occurs. This 17-year-old newborn presenting with acute bilious vomiting for 24 hours, was otherwise normal since birth. So this is me aspirating through the feeding tube. Here you can see the color, it's yellow, and this is bile, but a typical bile is green color. So bile can be green or yellow like this. When it's green, it's more reliable. You can be sure that it's bile. When it's yellow, this can be bile or some other secretions as well. So for midgut volvulus, bilious vomiting is important. So stop ordering urgent GI studies after hours for the investigation of non-bilious vomiting. It's important. Let me show you an example of a midgut volvulus. So as we said before, there is always malrotation when there is midgut volvulus, not vice versa. So here on the upper GI study, we can see the duodenum. The proximal part is slightly dilated. The contrast is passing slowly. There's a delay. But look at this. The DJ junction is not in normal position, but there is twisting of the duodenum. And the proximal jejunum, this twisted appearance is actually also, you can see it on the surgery. It's called corkscrew appearance, and this is pathognomonic for midgut volvulus. And volvulus is always almost always in the clockwise position, just like this one. And during surgery, they open the bowel and they actually detwist the bowel in the counterclockwise position to fix. Then they broaden the mesentery, and that's the surgical treatment. Another example with surgical uh, confirmation. Here, it's hard to tell because the bowel is twisted. So they just detwist on the counterclockwise position a few times, and then they broaden the mesentery. Here is the upper GI study, corkscrew sign. This is typical for volvulus. There is also malrotation because the DJ junction is not in normal position. What do we see on ultrasound when the complication of the volvulus occurs? We basically, the SMA is in normal position. Everything is twisted around the SMA in clockwise position. So there is mesenteric vein and there is duodenum around it. So they will be twisted and they will be obstructed. And for example, here, that's the SMV, that's SMA, that's aorta. So that's SMV is twisted and obstructed, so proximal part will be dilated. And this is duodenum. Again, proximal part is dilated and it's twisting around the SMA. Here, when you go distally, the SMV will be obstructed and the duodenum will be obstructed as you go distally. Here, again, you can show this by Doppler. This twisted appearance is pathognomonic. You don't have to do an upper GI study to confirm this finding. So if you do dynamic imaging, if you swipe your probe from up to down, you can see the twisting, and you can actually up and down, you can see this twisted appearance. And color Doppler usually doesn't add much, but it's called Whirlpool sign, and it looks like a hurricane actually. This hurricane is on the other side. The volvulus is in the clockwise position. We shouldn't be doing a CT study, but in some cases, they end up getting a CT, and this is in the midline. This is not malrotation. This is actually midgut volvulus. It's in the midline retroperitoneal, and you can see the twisted appearance. Let me end my lecture by showing you a case to show how dynamic can midgut volvulus be. They can be intermittent, and when there is a malrotation, underlying malrotation, they may come and go, and they may cause symptoms when midgut volvulus occurs. When there is no volvulus, the symptoms may resolve. In this patient had some abdominal pain, some symptoms for years, and not yet diagnosed. I am doing an upper GI study on a Friday in the afternoon. On the upper GI study, the findings were equivocal. I wasn't sure. There is no upper GI obstruction, so I'm sure that there is no midgut volvulus. There is no twisting of the duodenum, no corkscrew sign. And here the duodenum is crossing the midline. That's reassuring. But look at this. The small bowel is predominantly on the right side, not left upper abdomen. And although the duodenum is crossing the midline, the D3, the DJ junction is slightly below the level of the pylorus. And I wasn't sure, so I followed the patient to get a final image to show the TI junction. And the TI is in the right side of the abdomen, but a little bit high. So there is most likely some incomplete fixation here. So I wasn't sure. I described my findings. I said this is suspicious for malrotation, and the patient was doing fine. The symptoms, there were no symptoms. The patient presented to ER with acute symptoms, but when I was doing the study, the patient was completely fine. There was no pain. I could palpate the abdomen with no issues. So we decided to send the patient home, and the patient actually presented to ER early in the morning on Monday, and we ended up doing the CT study. And here you can actually see the SMV twisting around SMA in clockwise direction. And the colon is on the left. We can still see the colon because there is residual contrast. Let me show you again. The small bowel is on the right. The colon is on the left. The ileocecal junction is on the left. The DJ junction is on the right. So the bowel actually twisted completely, and there was midgut volvulus. Finally, take-home points. Malrotation of the midgut might have life-threatening complications. Thus, making prompt diagnosis can be life-saving. Bilious vomiting is the cardinal clinical sign. It is incumbent on the radiologist to make the diagnosis. The gold standard method for the diagnosis is upper GI study and based on demonstration of the position of the DJ junction. Thank you very much for listening.